with Dr. Muse. This is Dr. Richard Ulm. Brad just recently passed, I would say, the most difficult postdoctoral exam that I've ever taken. It's the McKenzie, certified McKenzie practitioner examination. Mm-hmm. Now, we wanted to just spend a little bit of time talking about this, to highlight the fact that he studied and was able to pass the test. I'd also passed it last year. But it's a really, really big part of our approach to just in the whole office, whether it's either the two of us or Dr. Meyer or Dr. Kraft. We all use this as one of the fundamental assessment tools, also for treatment, and also influences sort of long-term care of the patient. So I want to talk about that. The other thing that we wanted to kind of talk about is sort of highlight, what exactly is the McKenzie method all about, and why are we using that? So we're going to do our best, and I think we'll be fine to keep it somewhat short.
Yeah, definitely.
All right. Well, so first, congratulations or cheers to
thank you
passing our exam.
Congrats.
Yeah, congrats.
A year late, but
fair enough. Okay, so let's talk about what is McKenzie. So I mean, you just recently took the test, so it should be sharp in your brain.
So I think the easiest way to put it is that McKenzie is a method of classifying injuries or conditions that come into the office, and then with that classification, then that guides our treatment. So I think that is a huge benefit of it, where instead of just throwing random stuff at people and seeing what sticks, what we're able to do with McKenzie method is classify the injury, and then, like I said, that provides somewhat of a roadmap for us to see, okay, what category does this person fit into, and then how do we go about treating that patient? So,
but what he means by classification is it allows us to kind of more precisely dictate care for that patient. If you have somebody that comes in and let's say that they've got a problem and their problem is like inflammation in the body, okay, well, you're going to treat that one with medication or with nutrition. If they have a broken bone, then you're going to treat them, with obviously setting the bone and sort of stabilizing it. Right? It just depends on what it is. With McKenzie, we're able to go through and more precisely classify our musculoskeletal or, a lot of the orthopedic stuff that we see in this office. We classify them more precisely so that we're able to be more efficient and more effective with the care that we provide. That's what's one of the big things about McKenzie.
Right, and I think it kind of to build off of that, it's, we recognize we're not superheroes, so we're not going to be able to help everything. But if it's something that we, in all reality, won't be able to fix, the goal of McKenzie is to get us to that point quicker. So then now we know which portal to send you into. Do we need to send you to the orthopedic surgeon? Do we need to send you to maybe a neurologist or someone who's going to give us more of maybe like a PMNR doc to give us some pain medication so that we can then do our mechanical intervention? So the benefit of it a lot of times is figuring out what we need to do in a more rapid manner and hopefully not waste our patient's time.
Yeah. The thing that I like about it, and we'll get into maybe specifically what it would look like if you were to come in the office and sort of experience it, but the thing that I like about it is it takes the guesswork out of the exam. And if we sort of pan back a little bit and we think about the typical medical paradigm, they're going to use what I call a pathoanatomical model, which means you're finding something is wrong with anatomy, and they're going to sort of blame it on that. Pathological anatomy absolutely is a big influence, but what we don't know for sure, unless you do a really good exam, is that pathological anatomy actually contributing to the patient's symptoms? So a perfect example is you might have a patient that has a disc injury that typically the mechanism or the damage was done when they bent forward in a flexion. Well, they might also have some degeneration or arthritis on the back of the spine that might get injured or more provoked when they lean backwards. If you take an MRI and you just sort of look, you don't really know which one is causing the problem until you do a thorough exam, and that's where the McKenzie method comes in, because we use what I call a dose-response model. We basically try something to the body, like, okay, we're going to try gently mobilizing the spine into extension, and then we're going to recheck a lot of their baselines, which might be active range of motion, passive range of motion, the subjective, where is the pain? What's the intensity of the pain? Is it intermittent? Is it constant? That kind of a thing. And then we can confirm that, okay, yes, this direction, this exercise is absolutely improving the patient's symptoms. If we just look at an MRI or we just take a history, we can just kind of guess, like, yeah, I think it's coming from the disc, or yeah, I think it's coming from your SI joint, so I guess here's some exercises for you. There's still a little bit of guesswork going on there. With McKenzie, you take all the guesswork out because everything is 100% tailored to that patient that is in the room with you right there.
Right.
That's what I love about it.
Yeah, so to give an example on a first visit, we will say, we're going to figure out what your provisional diagnosis is. So hopefully, it'd be great if we figured out on the first try all the time, but this is where patient education, but then patient participation is very important. So I always tell people, okay, we're done for the first visit, but now the assessment continues. You doing these exercises at home and then coming back a day or 2 days later and then reassessing is just as important as anything else we just did in the office.
Or even more important. So when I'm teaching, I tell people that the most important part of the exam is your reevaluation the first time a patient comes back. Mm-hmm. It's much, much easier to get someone to feel better in one visit. Like they come in the first visit, you could do some soft tissue work on the back. We could throw some dry needles in there. You could do like a manipulation, give them a compliment, whatever. They're going to feel better for the most part that day. But we want to make sure that it has a lasting effect. And with the McKenzie method, we're going to send you home with one exercise that you're going to do repetitiously throughout the day. And then when we check back in with you 24, 40 hours later, we want to make sure that you have improved definitively prior to treatment. So if you're waiting until after the treatment to then assess them, it's like, yeah, I feel better. Okay, I want to know the next time they come in, they're like, oh yeah, it's definitely better. The intensity of my pain went from a 7 to a 4, or I got up in the morning and it warmed up within 20 minutes instead of 2 hours, or I could sit for this long without pain.
And I think we both would agree on this. The pain is not always the primary thing that we look for. So we try to give audits to the person. So maybe if it's a low back complaint, during the visit we'll dose response, see how do they feel, bending forward, bending back, side to side, rotating, and then we'll tell you, do your exercises while you're at home, and then you can do the audit yourself. Tell us, does that stuff change or does that stuff feel better as you go through these exercises?
Which is kind of life-changing. So I see a lot of people that have been to several physical therapists or several chiropractors, or they've tried injections or maybe even several surgeries, and it's oftentimes just totally life-changing to give them an exercise that they can do that gives them power over their symptoms. Yeah. Whereas prior to that, it basically was like, oh, my back's bugging me or my shoulder's bugging me, and they just sort of wait out the storm until it gets better. With this, what I love about it is that they now have a weapon that they can effectively reduce the severity, the intensity, or the duration or the timing of their symptoms, and so now they don't feel so sort of subserviated to their pain or their condition.
Right. That kind of fits into our whole methodology here, where it's, we want to empower the patient. So if we could show them that they can change it with movements they do themselves, then I don't think there's anything stronger than, opposed to us having them come in, okay, lay face down, let me do all these different therapies to you. Opposed to that, we're teaching them how to take themselves through a simple movement. And then we want you, the patient, to feel, does that change with whatever it is that you were having pain with? If it's reaching overhead, I want you to reach overhead again, and you tell me if that's changed with some of these movements that we did. So I think that's extremely powerful.
Yeah, the other neat thing about that is it's sort of trying to break the patient-client dependency. So in the beginning, if someone injures their back or their foot or their Achilles or their shoulder or whatever, what we do in there speeds up the recovery process for sure, and the patient is more dependent on the actual manual care that we do. But as we go through and we start addressing the problem and we're using McKenzie, that's going to involve the patient doing these exercises consistently, at home, along with lifestyle modifications like standing more than you're sitting or using a back roll or whatever. that's going to slowly break that dependency, and then now the patient has actual full autonomy over their symptoms, which is awesome.
Right.
Super cool.
So I wanted to switch gears a little bit and ask you.
Uh-oh.
We're talking all.
We did not talk about
we're
this.
talking all about McKenzie, but I want to know, how does that fit into your overall? Because I don't want to speak for you, but you don't do only McKenzie, right?
I do not do only McKenzie.
How does that fit into your overall treatment? And why is it better than maybe someone who only does one certain therapy or the other?
That's a good question. Okay, so my overall model, my overall goal, I think I kind of speak for everybody here, is we're trying to improve the patient's overall function. And that might mean movement quality, that might mean movement quantity, that might mean how well they can control their movements, how well they can just execute their everyday life stuff, whether that's, picking up a kid off the ground consistently or, running an ultra marathon. I'm trying to improve their overall ability to do those things. With McKenzie, you can identify problems that are blocking that more quickly than any other system that I know. By accurately classifying the patient, you can say, okay, this patient's gonna need these kinds of therapies, and it's gonna take about this much time. So the expectations are better, and I limit the amount of therapies that I'm trying to use on that patient, so I can be much, much faster with the treatment plan. So I love it because you're classifying the patients really, really well. The other thing is, if you have a case where they are a responder to the McKenzie method, it's incredibly quick. So, I mean, that's not to say that there's, not a decent amount of the patients that it requires, couple visits, couple weeks even of therapy. But if someone has, that pain down the back of their leg, or that low back pain that sort of radiates to the right, or, some neck pain, or they can't turn one way, or it goes under their arm, I don't know a faster tool or therapy or approach that can reduce those symptoms. So I love the speed of that. If they're an actual McKenzie responder, that's kind of where I would fit in. So McKenzie is going to be a big part of the assessment process in the beginning. It's going to be heavily utilized early on in the treatment plan, but where I think, McKenzie sort of runs out of steam, so to speak, is when we get into that restoration of function where, okay, you injured your back, picking up a bag of mulch off the ground or doing a deadlift or whatever. Okay, well, now we can get your symptoms gone. We can take the pressure off the back of the disc. We can have it where they no longer have pain down their leg or whatever. But now we need to teach them how to actually bend over and pick up something heavy. And we need to make sure that they're doing it in a way that does not provoke symptoms or cause injury. That's where the dynamic neuromuscular stabilization, or DNS, is a rehab approach that we can talk about some other time. Sure. It's a group that I teach for. So I'm going to use now the DNS. I'm going to dovetail it with the McKenzie. So when we get into that restoration of function, improve their movement quality, now I'm going after that with the DNS model. So it's McKenzie early on. If the patient is a responder to the McKenzie method, we're going to do that early on, and then it will blend into more of the rehabby, functional exercise kind of approach later on.
Yeah. So just the kind of what I pulled from what he just said, beginning the entire process with a new patient with almost more of a sniper scope perspective, trying to zone in on, okay, what's our portal of entry here, opposed to more of a shotgun approach where it's just throw everything at them and see what happens with them. So it kind of sets the stage for your entire treatment approach. And I think that's huge. The way that to kind of build off of what he was saying, I'd say we practice kind of like a chiropractic version of McKenzie method. We do it as we integrate different things. So the way that we integrate like the adjustment or some of the soft tissue stuff we do, I'll tell the patients it's more so just to make the McKenzie stuff that much more beneficial. So getting to end range is where the magic happens, is what they say. So if it's a press up, which is a very common one that you may see us do from the McKenzie method.
Press up is kind of like a cobra press you would see in yoga, but it's relaxed and you're letting your spine just kind of sag down as opposed to keeping everything engaged. And I think we sent out an email last week about the press up,
Yep.
or 2 weeks ago.
But sometimes there may be like a joint fixation that is stopping someone from getting to that full end range of motion. So maybe we do our chiropractic thing, we do the adjustment, and then it just makes the McKenzie exercise that much more beneficial. So I think that's something that we have going for us, that we can combine these really powerful tools to just make each of them work that much better. So.
Yeah, I think it's great. We don't want to run super long. I know that you and I could probably end up talking about this for 2 hours. So let's sort of finish with maybe just describing what a normal visit looks like and what the McKenzie method, like what it would be. So we talked about classifying the patients.
Correct.
Well, how we classify the patient, if somebody comes in, if you've never come and seen one of us, we're going to obviously take a history, like what happened, did you fall down the stairs, did it just kind of come on for no reason, did you just wake up with the pain, whatever it was. McKenzie's going to use what they call repetitive end range loading. So that's going as far back as the patient is capable, repetitiously. We're always going up to their tolerance, and we're not over-forcing, or we're not overdoing the force. We're always going what's called graded force progression. So we're starting light and working up with more force as long as the patient tolerates it. And based on the patient's symptom response to that repetitive end range loading, that's going to guide us on, okay, that exercise is good or that exercise is bad. Now, what we're looking for is called the direction of preference. And this applies to any joint in the body, but McKenzie is sort of very, very famous for applying it to the spine. The direction of preference is the direction in which you move that joint that produces a positive symptom response. So the range of motion goes up, the tenderness around it is better, maybe orthopedic tests that were positive before are no longer positive.
Right.
Their overall function, how far their symptoms are from that area, whether you're calling it radiation or peripheralization. We want positive response to those. And if we're going in, we're doing this repetitive end range loading, 2 sets of 10, 3 sets of 10, 10 sets of 10, whatever the case may be, in perhaps different directions, we're able to kind of find that direction of preference. And that ends up being the home exercise
Right.
that you talked about.
And I think especially within that first visit, to give a idea of what it would look like, we always, thorough history first, check the different motions. If it's lumbar spine, maybe it's bending forward, bending back, side to side. And I think our appointments are built in a fairly similar way. We're going to take you through some motions, see if we see any change. Then we draw some really bad pictures halfway through to explain what we're doing.
Yep.
And then we wrap it up with that. And like I said before, I always finish the appointment by saying the assessment's not over. The person going home with that exercise is the continuation of what we're doing in this office. So once again, putting the onus on the patient that this is their condition and they have the power to take care of it. So
that's kind of what allows us to be so patient specific. So the cheesy line I always say is that we have patient specific treatment plans, not condition specific. A lot of times you go into another therapist, be it a chiropractor or a PT, and you're just getting the same old hum-ho stuff that they would do for every hip problem that they have come in the door, or every neck problem, or all carpal tunnel. They're just getting the same exact thing. With the McKenzie method, we can probably finish here. With the McKenzie method, this is kind of how we tailor it specifically to the patient. So do you have anything else to add?
no, I think we did a pretty good job. I think that,
All right.
yeah.
I will say this, this is the McKenzie method, so I think there's less than 200 chiropractors in the world that have ever been certified in McKenzie, because McKenzie is predominantly, thousands of physical therapists have been certified in McKenzie over the last 60, 70 years, and only 200 chiropractors have ever been certified. So that is basically a really, really good symbol that we kind of blend chiropractic with traditional physical therapy. So we're going to use a lot of, obviously, the manual aspect that you get with traditional chiropractic care, be it soft tissue work like muscles or joint manipulation or mobilization, but then we're going to blend it with sort of the exercise approach that you might get at typical physical therapy. So I think that's a nice advantage here. It allows us to be pretty patient specific, and I think for the most part get good results.
Yeah, especially as a new physician here, it's a game changer in terms of you'll have those magical appointments where, you know, the person gets better almost instantly. Not always the case, but it can be a huge thing for a lot of people.
Yeah, no, it's pretty awesome.
Yep.
So that's good stuff. Congrats on passing your test.
Congrats to you too.
It's
a
still
year late.
It still feels good. So it was awesome.
Yeah.
So if you guys have any questions, go ahead and comment below or shoot us an email. We can gladly answer some questions. You know, if you've got any interest in the McKenzie method, you could look online at columbuscrc.com in our rehab section or our therapy section. You can also look it up at McKenzieUSA.com.
McKenzie Institute USA.
McKenzieInstituteUSA.com. That's going to have, you know, we'll both be featured on there as certified therapists.
You find us on the provider.
Yep.
thing.
But you can also learn a little bit about that there. It's just been a huge influence to all of our practices, including Dr. Kraft and Dr. Meyer. So it's a central piece of what we do here at Columbus CRC. And we just wanted to take a couple minutes or 20 minutes.
No.
That's actually better than I thought we were going to do, to kind of explain that. So if you guys have any questions, comment below. But I hope you guys have a great day, and we'll do this again soon.
Yeah. Thanks, guys. We'll talk to you later.